You take somewhere between 6,000 and 10,000 steps today. Maybe more. And for every single one of those steps, there is a joint in your body doing something your brain is not consciously aware of, something it stopped consciously thinking about so long ago that most people do not even know the movement exists. Not the hip, not the knee, not the ankle. Something smaller, something deeper, something that sits at the very base of your spine and quietly determines whether the rest of your body is moving correctly or slowly breaking itself down with every stride you take. And when that joint stops working the way it was designed to, nothing above it or below it can fully compensate. If that sounds important, it is because it genuinely is. And once you understand what this joint actually does, how it moves, why it stops moving, and what happens to your entire body when it does, you are going to look at the way you walk very differently. Not in an abstract way. In a way that changes what you do tomorrow morning when you get out of bed. So if you have found this channel useful before, now is a good time to subscribe and turn on notifications. Because this is exactly the kind of content we build here, the biology and psychology behind the things your body does that nobody ever explained to you. The joint we are talking about today is called the sacroiliac joint. Most people have never said that word out loud. Some people have heard it from a chiropractor or a physical therapist, usually started hurting, usually after it was already too late to catch the problem early. But the sacroiliac joint, or the SI joint as it is commonly abbreviated, is not a joint that lives only in the world of injury and pain management. It is a joint that is active every time you move, every time you stand up, every time you shift your weight from one foot to the other, and understanding it is not a niche interest for athletes or people with back problems. It is relevant to anyone who has a pelvis, which means it is relevant to every single person watching this right now. Let me tell you where it is first. Because location matters when you are trying to understand a structure. Your sacrum is the large triangular bone at the base of your spine. It sits between the two halves of your pelvis, the iliac bone, like a keystone wedged into an arch. The place where the sacrum connects to each iliac bone on either side is the sacroiliac joint. There are two of them, one on the left and one on the right, and they sit roughly in the area where two small dimples appear on either side of your lower back, just above the line where your waistband typically sits. If you reach back right now and press your thumbs into those two spots, you are pressing almost directly on top of them. They are not deep, they are right there, and they have been right there for your entire life, doing something your brain long ago decided it did not need to pay attention to. Here is what makes the sacroiliac joint unlike almost every other joint in your body. Most joints are designed primarily for mobility. Your shoulder rotates freely through a wide arc. Your knee bends and extends through a significant range. Your ankle tilts and points and pivots. But the sacroiliac joint is not primarily a mobility joint. It is a force transfer joint. Its primary job is to take the mechanical forces generated by your legs during walking, running, climbing, and sitting down, and transfer them into the axial skeleton, the spine and rib cage, efficiently and without damage. Think of it like a mechanical coupling between two systems that are moving at slightly different rhythms. Your lower body generates momentum and ground reaction force. Your upper body needs to receive and redirect that force without absorbing it as damaging compression. The sacroiliac joint is the interface between those two systems, and it does this through a very specific, very small movement that most people have never been told about. That movement is called nutation and counternutation. Those are the two positions the sacrum moves through relative to the ilium with every step you take. Nutation is when the top of the sacrum tips forward and the coccyx, the tailbone, moves backward. Counternutation is the opposite. The top of the sacrum moves back and the coccyx moves slightly forward. This motion is small. We are talking about 2 to 4 millimeters of movement and roughly 4 to 8 degrees of rotation in most people. It is not a movement you can see in a mirror. It is not a movement you can feel easily unless you are specifically trained to notice it. But that tiny motion is what allows your pelvis to act as a shock absorber, to rotate correctly during the gait cycle, and to distribute load evenly across the structures above and below it. When nutation and counternutation happen freely and rhythmically with each step, your body moves the way it was designed to move. When that movement is restricted even slightly, every structure connected to the sacroiliac joint has to compensate, and those compensations are not free. They cost something, usually over years, and usually in the form of pain in places that seem entirely unrelated to the pelvis, the lower back, the hip, the knee, even the foot. Dr. Andrei Vleeming, one of the foremost researchers in sacroiliac joint biomechanics, whose work at Erasmus Universities for how physical therapists and osteopathic physicians understand pelvic mechanics today, described the sacroiliac joint as a self-locking mechanism, one that depends on both the shape of the joint surfaces, which he called form closure, and the tension of the surrounding muscles and ligaments, which he called force closure, to function correctly. That distinction matters more than it might initially seem. It means that the sacroiliac joint does not work in isolation. It is part of a system, and that system depends on the active participation of muscles most people never think about. When those muscles are weak or tight or out of coordination with each other, the self-locking mechanism stops working optimally. The joint loses its ability to transfer force efficiently, and the brain, which is always trying to solve the problem of locomotion as cheaply as possible, starts rerouting mechanical load through paths it was not designed to use indefinitely. This is where the psychology becomes inseparable from the biomechanics. The brain does not think about your sacroiliac joint while you walk. It does not think about most of what your body is doing while you walk. Walking is what neuroscientists call an automated motor pattern, a behavior that, once learned in early childhood, gets delegated to lower levels of the nervous system so that higher cortical functions can focus on other things. The spinal cord, the cerebellum, and the basal ganglia manage the rhythmic, repetitive mechanics of locomotion almost entirely without conscious involvement. This is enormously efficient. You can walk and think about a problem, walk and carry a conversation, walk and read a sign across the street, precisely because your brain has handed off the mechanical execution to systems that do not require your attention. But here is the cost of that efficiency. When something in the automated pattern stops working correctly, the brain's corrective response is not conscious. It does not generate a clear error message that says your sacroiliac joint mechanics are compromised. It makes subtle, often invisible adjustments at the level of the automated systems, compensations that work well enough in the short term, that keep you moving forward, but that slowly accumulate structural consequences that eventually become impossible to ignore. Researchers studying gait asymmetry have documented this process in clinical populations and in healthy adults alike. A study published in the journal Clinical Biomechanics found that sacroiliac joint dysfunction produced measurable asymmetries in ground reaction force patterns during walking, meaning that without any conscious awareness, subjects were distributing weight differently between their left and right sides in response to impaired force transfer at the SI joint. The asymmetry was not dramatic, it was not a limp. It was subtle enough that the subjects themselves did not perceive it as unusual. But that kind of subtle, long-duration asymmetry loads the joints, discs, and soft tissues of the lower body unevenly, and uneven loading over time is one of the most reliable predictors of musculoskeletal breakdown. The brain forgot to check on the sacroiliac joint, and the body paid for it slowly and quietly. Now let us talk about how sacroiliac joint dysfunction actually develops, because it rarely happens from a single dramatic event. Most cases develop through one of three pathways, and the three pathways are surprisingly common, so common that you will likely recognize yourself in at least one of them. The first pathway is prolonged sitting. When you sit for long periods, particularly in a position where your pelvis tilts backward and your lumbar spine flattens, the muscles that create force closure around the sacroiliac joint, specifically the deep spinal extensors, the gluteus maximus, the biceps femoris and the piriformis, go into a state of reduced activation. They do not turn off entirely, but they lose the precise, coordinated timing of their contractions that the joint depends on for stability. Do this for 8 hours a day, 5 days a week, for years, and the muscular system that was supposed to be holding the SI joint in its optimal self-locking position loses the neural coordination to do so consistently. The joint starts moving in slightly altered patterns. The brain's automated motor program compensates, and somewhere downstream, something starts to hurt. The second pathway is leg length discrepancy, either structural, where one leg is genuinely shorter than the other, or functional, where a difference in muscle tension or joint restriction creates the mechanical equivalent of a shorter leg without any actual difference in bone length. Research suggests that a functional or structural leg length difference of as little as 5 millimeters can be enough to alter sacroiliac joint mechanics bilaterally, because the pelvis has to tilt to accommodate the discrepancy on every single step, and that tilt changes the mechanics of both SI joints, not just the one on the shorter side. This is one of the reasons that lower back pain so often presents on the opposite side from the painful hip. The body is compensating across multiple joints simultaneously, and the place where the compensation fails is not always where the original problem is located. The third pathway is pregnancy and postpartum changes in ligament laxity. During pregnancy, the hormone relaxin causes a systemic loosening of ligamentous tissue to allow the pelvis to expand for delivery. This is essential and brilliant physiology, but it does mean that the ligamentous component of force closure is temporarily reduced, and the muscular system must pick up the slack. In the postpartum period, when the muscle coordination system is often disrupted, the sacroiliac joint can develop instability patterns that persist long after relaxin levels return to normal, sometimes for years, because the muscular coordination never fully recalibrates without targeted intervention. If you are finding this genuinely useful, the most helpful thing you can do right now is share this video with someone you know who has dealt with unexplained lower back pain or hip discomfort, because there is a real chance they have never heard this explanation before. And this is exactly the kind of information that changes how people understand what their bodies are telling them. Here is what happens above and below the sacroiliac joint when its mechanics are compromised, and this is the part that surprises most people. Above the joint, the lumbar spine is the immediate neighbor, and when the sacrum is not nutating and counternutation correctly, the lumbar vertebrae are forced to absorb and redirect forces they were not designed to manage alone. The intervertebral discs, those fibrocartilaginous shock absorbers sitting between each vertebral body, are particularly vulnerable to asymmetric loading. Research on disc degeneration consistently shows that asymmetric compressive and shear forces accelerate the breakdown of the disc's outer ring, the annulus fibrosus, in ways that symmetric loading does not. This is not a dramatic or sudden process. It is a slow, cumulative degradation that takes years to become symptomatic, which is one of the reasons lower back problems are so common and so difficult to treat by the time most people seek care. They are not addressing the original dysfunction. They are addressing the downstream consequences of it. Below the joint, the hip is the immediate neighbor, and the hip is exquisitely sensitive to how the pelvis is positioned and moving. The femoral head, the ball at the top of the thigh bone, articulates with the acetabulum, the socket in the pelvis, and the position of that socket is determined partly by how the ilium, the pelvic bone that forms one side of the sacroiliac joint, is rotated. When the ilium is stuck in an anteriorly or posteriorly rotated position because SI joint mechanics are restricted, the acetabulum is not pointing in its optimal direction, and the femoral head is not sitting in its optimal position within the socket. Every hip movement from that altered baseline creates slightly abnormal contact pressures within the joint. Over time, those abnormal contact pressures contribute to labral fraying and cartilage wear, which are increasingly common findings on hip MRIs in adults who have never had a traumatic hip injury. The knee, one joint further downstream, receives altered rotational forces as a consequence of hip positioning changes. Altered knee rotation mechanics are among the most well-documented contributors to patellofemoral pain syndrome and medial compartment osteoarthritis, and the foot, at the bottom of the chain, compensates for everything above it through changes in mechanics and ground contact pattern that create their own set of cumulative consequences. This is not a single joint problem. This is a cascade, and it begins, more often than most people realize, at that small overlooked interface between the spine and the pelvis. Now here is where things get practical, because understanding the problem is only useful if it points towards something you can actually do. The first thing worth knowing is how sacroiliac joint dysfunction is assessed, because the itself tells you something important about the nature of the problem. There is no single definitive imaging test for SI joint dysfunction. X-rays can rule out structural damage. MRI can identify inflammation in the joint capsule. But neither imaging study reliably identifies the functional restriction, the loss of normal nutation and counternutation movement, that is at the root of most non-inflammatory sacroiliac problems. This is why the condition is so often missed in standard medical workups. The doctor orders an X-ray, the X-ray looks normal, and the patient is told there is nothing wrong with the joint, when in reality there is a functional restriction present that imaging was never designed to detect. The assessment tools that do work are hands-on clinical tests like the Gillett test, the standing flexion test, the posterior shear test, and the thigh thrust test, tests that are performed by a clinician who is manually feeling for asymmetry and restriction in joint movement and tissue tension. These tests have been validated in the research literature, with a cluster of positive findings across multiple tests being significantly more reliable than any single test in isolation. The key takeaway is that if you have been told that your imaging looks fine, but you continue to have lower back, hip, or pelvic pain that does not have a clear explanation, a hands-on evaluation of sacroiliac joint mechanics by a skilled physical therapist, osteopathic physician, or chiropractor with specific pelvic biomechanics training is genuinely worth pursuing. What does it actually take to restore normal sacroiliac joint function once it has been lost? This is where we need to be precise, because not all interventions address the problem at the correct level. Manipulation and mobilization techniques, the kinds performed by skilled manual therapy practitioners, can restore movement to a restricted joint when the restriction is joint level rather than primarily muscle level. Research supports short-term benefits of sacroiliac joint manipulation for certain presentations of SI joint dysfunction, with studies showing immediate changes in pain intensity and movement restriction. But manipulation alone is not a complete solution, because it addresses form closure, the mechanical position of the joint, without necessarily addressing force closure, the muscular and ligamentous system that keeps the joint in its optimal position during movement. This is why people who receive manipulation for SI joint problems often feel better immediately and then return to the same problem weeks later. The joint was repositioned, but the system that was supposed to be stabilizing it was not retrained. A complete restoration strategy has to work on both levels simultaneously. The joint needs to be mobile enough to allow the small nutation and counternutation movement that walking requires, and the muscular system needs to be coordinated enough to manage the joint through that movement under load. The muscles most directly involved in force closure are the transversus abdominis, the deep fibers of the multifidus, the gluteus maximus, the biceps femoris long head, and the adductor magnus. These are not the muscles you are typically training in a standard gym workout. They are deep, postural, coordination-dependent muscles, and training them effectively requires specific movements performed with specific timing and awareness. Research by Professor Paul Hodges at the University of Queensland, whose work on motor control and spinal stability has been enormously influential in physiotherapy, showed that in people with chronic lower back and pelvic pain, the deep stabilizing muscles, particularly the transversus abdominis and deep multifidus, demonstrated a delay in their pre-activation timing relative to movement. In healthy subjects, these muscles activate slightly before any limb movement occurs, bracing the lumbar spine and pelvis before the perturbation of movement arrives. In people with pain and dysfunction, that pre-activation timing is disrupted. The muscles are still contracting, but they are contracting too late to provide proactive stability. The joint is catching up to the movement rather than being stabilized before it. Exercises specifically designed to retrain this pre-activation timing, slow, awareness-based movements that require the deep stabilizers to engage before the load is introduced, are significantly more effective for long-term sacroiliac joint stability than high-load exercises that bypass the coordination component entirely. Here is something you can do right now, not as a substitute for professional evaluation if you genuinely have a problem, but as a way of beginning to reconnect with the movement pattern this joint was designed for. Stand up. Put your feet hip-width apart and feel the ground under both feet equally. Now very slowly shift your weight onto your right foot, just barely, just enough to feel the left side of your pelvis rise fractionally. Then shift slowly back to center, and then to the left. Do this for 30 seconds slowly, with complete attention to the subtle weight transfer happening at the base of your pelvis. What you are feeling or trying to feel is the movement that should be happening automatically and rhythmically during walking. The slight alternating tilt and rise of the pelvis that allows each side of the sacrum to nutate and counternutate with each step. For most people, this movement feels unfamiliar, not because they lost it yesterday, but because they stopped consciously noticing it years ago when the brain handed locomotion over to the automated system. That conscious reconnection, that deliberate attention to a movement pattern the brain forgot to supervise, is the beginning of the retraining process. It is not the whole solution. But awareness is always the first step before change is possible. Research on motor learning consistently shows that movement patterns cannot be refined without the attentional component. You cannot improve a movement you are not aware of, and this particular movement has been invisible to most people their entire adult lives. Let me close with something worth sitting with. We are living through an era of remarkable medical imaging, diagnostic technology, and surgical capability. And yet lower back pain is the single leading cause of disability worldwide, affecting roughly 619 million people globally according to estimates published in The Lancet, a number that has been rising steadily for decades. Not declining, rising. Something about the way we are thinking about this problem is not working. And one piece of the puzzle is that we are very good at treating structures, disc herniations, nerve compressions, and joint degradation, and much less attentive to the functional patterns, the small, repeated, movement-level dysfunctions that cause those structural problems to develop in the first place. The sacroiliac joint is not a dramatic structure. It does not make headlines. It does not generate the kind of surgical cases that build hospital departments. But it sits at the mechanical center of the human walking pattern, the movement that human beings have performed more than almost any other across the entire span of our existence. And when it stops cycling through its 2 to 4 millimeters of nutation and counternutation on each step, the consequences spread upward and downward through the body in ways that take years to become undeniable. The brain forgot to watch it. The medical system rarely thinks to assess it. And so millions of people carry compensations in their gait, in their posture, in the way they rise from a chair or descend a staircase that are connected to a joint whose name most of them have never heard. That is the kind of gap that knowledge can close. Not immediately, not dramatically, but in the quiet, cumulative way that understanding always works. Once you know what you are looking for, you start to see it everywhere, in the way you stand, in the ache that shows up on the left, but originates on the right, in the way your hip catches slightly at the bottom of a step, in the way your lower back feels when you have been sitting too long and you first stand up. Those are not random events. They are signals from a system that is working hard to compensate for something small and specific that it was never designed to carry alone. If you have been dealing with any of the patterns we described today, unexplained hip discomfort, one-sided lower back pain that does not have a clear structural cause on imaging, or a general sense that something about the way your body moves is slightly off, a thorough hands-on pelvic evaluation is genuinely one of the most underutilized assessments in routine healthcare. The tools exist, the practitioners who know how to use them exist, the research supporting their effectiveness exists. What is missing, usually, is simply the knowledge that the problem might be there, the knowledge that there is a joint at the base of your spine that your brain stopped watching a long time ago. That might be quietly changing the way everything above and below it works. Now you have that knowledge, and if this video gave you something genuinely useful today, consider sharing it with someone who might need it, subscribing if you are not already here, and leaving a comment below about what part of this connected most with your own experience, because that conversation is exactly what makes this kind of content worth building. Your body has been sending signals. Now you have a better framework for reading them.